blockers. And of course, those things will also treat the underlying hypertension if the person has hypertension as a cause of the hypertrophic cardiomyopathy. The second category of cardiomyopathy that the book discusses is restrictive cardiomyopathy. And they compare and contrast the myopathies side by side in figure 1.8 on the next page, on page 8. But with an infiltrative or restrictive cardiomyopathy, what you're dealing with is some substance, depending on what the disease is, that infiltrates or accumulates in the heart muscle. And they mention a number of substances that can accumulate, such as the protein amyloid and amyloidosis, such as iron and hemochromatosis, sarcoid nodules in sarcoidosis. Patients can develop cardiac sarcoidosis as well as pulmonary sarcoidosis. And they point out that the pathophysiology is similar to what you see in cardiac hypertrophy, in that the left ventricle becomes stiff, and there's decreased filling of the chamber during the diastole. With infiltration, you can also see abnormalities of systolic dysfunction. The treatment of restrictive cardiomyopathy is going to involve the treatment of the underlying disease. So if you're dealing, for example, with hemochromatosis, which is an iron deposition disease, an iron overload disease, the treatment is going to be with chelation to try and chelate or bind the iron and get it removed by the kidneys. If you're dealing with amyloidosis, the treatment is going to involve treatment of the underlying amyloidosis, which is not very effective. And if you're dealing with sarcoidosis, the treatment, again, is going to involve treatment of the sarcoidosis, which often involves use of systemic steroids, or maybe substances like methotrexate or something like that. Okay, finally, the last type of myopathy that you can see, cardiomyopathy, is a dilated cardiomyopathy. Okay, and they discuss the more general topic of cardiac dilatation at the bottom of page 7. They point out a number of different agents or etiologies can underlie the development of cardiac dilatation. So they point out, for example, alcohol. Alcoholic cardiomyopathy is something that is not uncommonly seen. Alcohol is toxic for lots of tissues, including cardiac muscle. And so patients who are alcoholic can develop alcoholic cardiomyopathy, or dilated cardiomyopathy. They mentioned viral myocarditis that can cause a dilated cardiomyopathy. That, of course, was anybody saw the movie Beaches, that's what happens to the brunette in Beaches. Remember, the two friends. You got what's Bette Midler and her friend, whatever her friend's name is, and the friend is the lawyer who then gets the viral myocarditis, and it's curtains for her. The other time you can see dilated cardiomyopathy, and we talked about cardiac hypertrophy, and we said that that's the way the heart responds to a pressure load. That's the way the ventricles respond to a pressure load, is they hypertrophy. But the way that the ventricles respond to a volume overload is with dilatation. And so you can also see dilated cardiomyopathy in conditions that expose the ventricles to a volume overload. You see that discussion at the top of page 7, the second column. It says dilatation occurs when the heart needs to handle more blood than usual. They give an example of that. They list aortic regurgitation or aortic insufficiency as an example of that. Okay? So if you think about it, if you have aortic insufficiency, so you have the left ventricle, and let's say the normal, volume that's ejected. We'll just make up a number. Okay, let's just say it's 60 cc's. Okay, it's 60 milliliters, let's say, with each heartbeat. Now the patient, that's in a patient that has an intact aortic valve. Okay, but if the person has aortic insufficiency, depending on the severity, a certain fraction of that blood is going to come back, right? All right. So let's say that a quarter of it's coming back, 25% is coming back, okay? Which means that if you eject 60 cc's out into the aorta, okay, since 15 are coming back, 1/4, 25%, 15 cc's are coming back, you're really only ejecting 45 cc's. You see that? So to make that up, the heart has to eject more blood. It has to eject 25% more blood because it knows 25% is coming back. So you do the math, whatever 25% of 60 is. So instead of ejecting 60, it's going to eject whatever, 75. That's a volume load on the left ventricle. Everybody see that? It's not a pressure load, it's a volume load. Every time it beats, it has to eject more. So the way it handles that is by dilating, okay? And in the early stages, that can be compensatory and physiologic. But when it becomes, at a certain point in time, the dilatation then becomes, it gets out of hand, and it becomes irreversible, okay? All right, and so that's why it's important to recognize that somebody has valvular insufficiency before the ejection fraction starts to fall. Because once the ejection fraction starts to fall, then the prognosis of the patient it goes down. Let's see, they list a number of other conditions. They list mitral regurgitation also as a cause of volume overload on the left ventricle, right? That might seem, well, how can, I understand how an leaky aortic valve is a volume overload, but why is a leaky mitral valve volume overload? Because again, the ventricle, the left ventricle, is ejecting blood. If you have a leaky mitral valve, it's ejecting blood forwards and backwards, right? It's whether it's going into the aorta or whether it's going into the pulmonary vasculature, it's still of no use if it's not going out where it's supposed to go. So that's a volume load as well. They list a number of conditions that can cause the right ventricle to be volume overloaded, including pulmonic regurgitation, which is the equivalent of, it's the right-sided analog of aortic regurgitation, and tricuspid regurgitation, which again is the right-sided equivalent of mitral regurgitation. They also mention atrial septal defects, which we haven't talked. Did you talk about atrial septal defect in anatomy or any? Have you spoken
CMS.
about them yet?
Yesterday, CMS.
Okay, so they point out that both ASDs and VSDs, ventricular septal defects, are going to because of the pressure difference. Okay, pressure's on the left side of the heart greater than pressure's on the right side of the heart. So what's going to happen is that the blood is going to be shunted to the right side of the heart, and that is going to constitute an increased volume load for the right ventricle. The right ventricle is going to have to deal with an increased volume load. So all of those conditions produce an increase in the volume workload of the right ventricle. And so you can see you can have problems with dilatation of either the right ventricle or the left ventricle. One thing I should make clear, the atria cannot hypertrophy. That's not something that they have available to them. Okay? So the atria, if you expose them either to a volume load or a pressure load, all they can do is dilate. And they can only dilate so much, and then they pass it on to the vessels that are feeding them. Okay? So you start to see, if it's the left atrium, you start to see pulmonary pulmonary hypertension. If it's the right atrium, you start to see systemic venous hypertension. In terms of the consequences of cardiac dilatation, they point out that you see systolic dysfunction as the ventricle dilates. Once it gets past a certain point, its effectiveness, its mechanical effectiveness goes down. So contractility goes down. You've stretched it too much. Contractility goes down. And let's see, they point out systolic dysfunction like that caused by cardiac dilatation can also occur from weakening of heart muscle secondary to ischemia. Dilatation is not the only thing that causes systolic dysfunction. Certainly, ischemia does it as well. Ischemia produces multiple pathophysiologic disturbances, okay? If the heart muscle, let's say the left ventricle, is not getting enough blood and the ventricle becomes ischemic, systolic function is going to go down. But diastolic function will as well. And an ischemic ventricle is often stiff, okay? We'll talk about that when we talk about the heart sounds. The management of dilated cardiomyopathy, they point out, is going to be the same as the management for heart failure. Going to use diuretics, going to use vasodilators, going to use converting enzyme inhibitors, angiotensin receptor blockers. So take a look at Figure 1.8. It does a pretty good job of comparing the different types of cardiomyopathy side by side by giving you examples of the different causes of each of those cardiomyopathies and giving you associated abnormalities on physical exam. And actually, since we sort of brushed over it, so we should talk a little bit more about some of the things that they mention in that figure. You see they mentioned that cardiac hypertrophy is associated with an S4, okay? We haven't talked about that yet because we haven't talked about the heart sounds yet, but we will. But the S4 is the fourth heart sound, okay? It precedes S1, comes right before S1, and you would typically hear an S4 in patients that have a stiff left ventricle, okay? So you can hear it in patients, for example, that have a cardiac hypertrophy. You can hear it in patients that have an ischemic left ventricle, okay? So if somebody who normally doesn't have an S4, if they're having, let's say, an anginal episode and they have enough ischemia to render the left ventricle stiff, you might actually hear an S4 appear, and that's a reflection of the underlying ischemia and diastolic dysfunction. And you contrast that with the dilated cardiomyopathies. Those people are more likely to have an S3. S3 is the third heart sound. It follows the S2, okay? And again, this is associated with chamber dilatation. The S3 is associated with the passive phase of diastole, the passive phase of ventricular filling. And the S4 is associated with the active phase of ventricular filling. By that I mean it's the part of ventricular filling that's dependent on the atrial kick. So if the last few drops that get squeezed into the ventricle, the left ventricle, by the left atrium, they don't go passively. Okay, the atrium kicks, it puts the last few drops in it, and then when the pressure is high enough, then remember that valve closes, right? So what that means is that you can't have an S4 in somebody that doesn't have atrial contractions. You can have an S3, but you can't have an S4. So for example, if somebody has atrial fibrillation and they're atrial fibrillating, and you say, I heard an S4, well, you didn't hear an S4. You heard something else, but you didn't hear an S4. They can't have an S4 if there is no atrial contraction. All right. Any questions before we turn to valvular disease of the heart? There's a couple of things I want to direct your attention to one other topic that's related to what we just talked about. And that's the topic of left ventricular remodeling. Left ventricular remodeling. Remodeling can be pathologic or physiologic, but what I want you to do is, if you go to Up to Date and you look and you just search for left ventricular remodeling, you'll see that they will discuss two different types of remodeling. They'll discuss concentric remodeling and they'll discuss eccentric remodeling. And these have overlaps with hypertrophy and dilatation, the hypertrophy and dilatation that we just talked about. So I want you to take a look at, there's a little diagram there on Up to Date that it'll look like this. Okay, it'll have pictures of concentric and eccentric hypertrophy side by side. So take a look at that. And a couple of things I want you to take note of in Up to Date's discussion of that. If you look at the concentric remodeling, what happens is that the wall thickness is increased. The relative wall thickness is increased. And the absolute, make sure I get this right. Hold on one second. Yeah. So with the concentric hypertrophy, the left ventricular wall thickness increases. The left ventricular end diastolic volume goes down, and so as a result of that, the relative wall thickness goes up quite a bit, because the relative wall thickness is calculated by the left ventricular wall thickness divided by the left ventricular end diastolic volume. So since the numerator is getting bigger and the denominator is getting smaller, then the product, the relative wall thickness is getting much increased. And that you contrast that with patients that have eccentric hypertrophy, where the relative wall thickness, which again is calculated by the left ventricular wall thickness divided by the left ventricular end diastolic volume, is either normal or reduced. And that, again, is depicted schematically up to date. They do a good job of showing the difference between those two types of remodeling. And we'll talk more about remodeling a little bit later, but I just wanted to make sure to draw your attention to that now. Okay, so let's talk first about the heart sound before we talk about the valves. We talked about a little bit about S3, we talked a little bit about S4. S1, you know, is the sound that's made by the closure of the atrioventricular valves. It's produced by both mitral and tricuspid closure. Usually the mitral is producing the predominant proportion of the sound. S2 is the sound that's made by aortic and pulmonic valve closure. You remember that S1 normally does not split. You don't normally hear a split S1. S2 does split normally physiologically. And do you remember that it's respiratory dependent, right? So how does that work? Why does that happen and how does it work? Go ahead.
Are you asking?
I'm telling you, when you hear, do you guys talk about splitting yet in physical diagnosis? Splitting of
A
S2?
little bit in CMS.
Okay, so what happens when, explain splitting of S2 to me.
It's when, I honestly don't.
Anybody?
know enough to.
Anybody want to explain it?
Yeah, it's like, well, they're not in sync, so there's a little bit of a gap, I guess you could say.
Is it because of the negative pressure when you inhale?
What's that?
Is it because you make a negative pressure in the thoracic cavity when you inhale?
Okay, so there's respiratory variation. What happens is that as you inspire, okay, you generate increased negative pressure in the thorax, and so that increases blood return to the heart, right, to the right side of the heart. And so what happens is that the increased filling of the right ventricle, okay? Now normally, what that's going to do is that's going to push back the P2 component of the S2, right? So S2 is equal to A2 plus P2, those two sounds, right? So you have A2 and P2, okay? And as you get, even have it, might be in one of these diagrams. Yeah, this will work. So you see here, here's there's the mitral valve component of S1, tricuspid valve component of S1, pulmonic valve component of S2, aortic valve component of S2, right? Well, they're showing aortic stenosis though. So normally, yeah, let's use this one. So aortic component of S2, pulmonic component of S2. And normally they're very close to each other, okay? But when you inspire, what happens is that you increase blood return to the right heart. It takes longer for the right ventricle to eject that increased volume of blood. Okay, so mechanical systole is delayed. And so what happens is that P2 moves out when you take a deep breath, and then it moves back when you expire. Okay, so you get increased splitting of S2. It's respiratory variation. Okay, so it's best heard, right, when the patient is taking slow, deep breaths. And again, you're going to listen. You're going to listen at the base of the heart. Okay, the aortic area, pulmonic area. You don't usually get splitting of S1, okay? To get splitting of S1, for a couple of reasons. First of all, because the pulmonic, the tricuspid valve closure sound is so quiet, okay? Number one. And secondly, they're so close together that we don't usually perceive a splitting of S1. So if you think you're hearing a splitting of S1, you may be hearing an S4 and an S1. okay? Or you may be hearing an S1 and an ejection clip, but you're probably not hearing a splitting of S1. In order to have a splitting of S1, you have to have a number of things go wrong, okay? What's the matter?
Is S4, is that like right before?
S4, S1,
Okay.
S2, S3, yeah. S4 comes right before S1. So if in order to get a split S1, you have to have multiple things go wrong, okay? So you have to have pulmonary hypertension to increase the pressures on the right side of the heart and make those noises louder. And you also probably have to have a right bundle branch block to separate out, to delay valve closure, tricuspid valve closure. Okay, so pulmonary hypertension, a right bundle branch block, you might have a split S1, but otherwise probably don't have a split S1. All right. Okay, let's talk about the different aortic valve diseases. First one they talk about is aortic stenosis. They point out that, again, we've alluded to this before. You can have valvular aortic stenosis, which affects the valve itself. You can have IHSS, or hypertrophic cardiomyopathy, which is a non-valvular aortic stenosis. It's below the level of the valve. That it's an aortic stenosis that is located below the level of the valve. And you can even have a supravalvular aortic stenosis if you have something in the aorta that is causing interference with ejection of blood from the left ventricle. In terms of the valvular causes of aortic stenosis, you can have, they point out that you can have just calcific aortic stenosis, which you can see with aging. You can see some patients with aortic stenosis are born with a congenitally bicuspid aortic valve. You know that the aortic valve normally looks like a Mercedes-Benz sign. It's a tricuspid valve, but some people are born with a bicuspid valve, and that is predisposed to early calcification. And so patients that have a bicuspid aortic valve can develop early or premature calcification of the aortic valve, calcific aortic stenosis. You can also get aortic stenosis from rheumatic heart disease. Okay, we don't see that so much anymore, but it can happen. In terms of, have you done anything in the lab with the simulations of heart sounds and stuff like that?
Not yet.
Okay. So let's see. We'll talk a little bit, and then maybe I'll find the site that will allow you to hear these things. So in terms of the murmur of aortic stenosis, it is a systolic murmur. Okay, that makes sense because murmurs are produced by turbulent flow, and so you can produce turbulence in two different ways. Okay, you can produce turbulence either by decreasing the size of the orifice through which the blood is passing, okay, or increasing the volume of blood that has to pass through even a normal sized orifice. Okay, so let's say that that's a normal size. Let's say that this is a normal size. This is a normal size orifice valve, okay, that we have to eject blood through, okay? We could produce, you can't really see it very well, can you? All right. All right, sorry about that. Okay, so let's say that this is a normal size orifice through which we're going to pass the blood, okay? One way that we can produce a murmur is by shrinking the orifice from this big to this big, okay? If you keep everything else the same, in other words, you're ejecting the same amount of blood through it, it's going to be turbulent and it's going to make a noise. It's going to produce a murmur. The second way that you can do it is keep the orifice the same size, but increase the amount of blood that you're forcing to go through that orifice in any unit time. Okay? So let's say let's say I had to get a, let's say I had to get a, 12-ounce bottle of beer, okay, through this thing in 1 second, okay? That would be normal, let's say, okay? Well, now instead of being a 12-ounce, let's say you make it a 24-ounce. You got to get it through there in the same unit of time. It's going to be turbulent, and so it's going to produce a murmur. So what that means is that you can produce a murmur of aortic stenosis in 2 ways, a murmur that's consistent with aortic stenosis in 2 ways. It can sound like aortic stenosis. Either you have true aortic stenosis where you have narrowing of the valve, or you could have somebody that has like a functional murmur where, let's say you give somebody has a fever, or their cardiac output is increased, let's say because they just ran a 100-yard dash or something. That can produce a flow murmur because you're increasing the volume of blood that you're passing through a normal valve in a unit time. And so you have to understand that not every time you hear a murmur is it going to be true aortic stenosis. It could be aortic stenosis, or it could be a flow murmur. The murmur associated with aortic stenosis, as the book points out, is a crescendo-decrescendo murmur. So it is a diamond-shaped murmur when it's depicted schematically. Sort of has a diamond shape there. It's maximum in the center of systole, in the middle of systole, and then it decreases in intensity as flow across the valve decreases. They also talk about in the patients that have true valvular aortic stenosis, they talk about sometimes you can hear changes in the S2 sound, and that makes sense because S2 is the sound made by the valve closure, including A2. And so I think it's important just to mention, just very briefly, the determinants of S2 intensity. So what determines how loud S2 is? Okay, a lot of these things you can reason your way to if you think about it. But one determinant of S2 intensity is the PR interval. So there's the P wave, there's the R wave, okay? The PR interval is going to be one determinant of S2 intensity, okay? Because what's going to happen is that as the P2 interval, so let's think about what's happening. With the R wave is electrical activation of ventricles, and which is followed then by mechanical systole. Okay, so when we get mechanical systole, the valves are going to open. Okay, and then they are going to, let's see, I'm trying to remember this, how this works again. Go back for a second. Okay, so let's go here. Okay, so let's see. This is systole. All right, so ejection, closure of the. This is going to be closure of the atrioventricular valves, right? No, closure of the
Aortic.
yeah, aortic and pulmonic valves. Then you get isovolumic relaxation of the ventricle. Okay. Then you get opening of the AV valves, and then you get filling of the ventricle, and then you get you get closure of the AV valves, you get isovolumic contraction, and then you get opening of the aortic valve, ejection, and then closure. Okay, so this is going to be the sound. This is going to be S2. Okay, at this point in time. Okay, and when you get closure of this valve, and this is going to be S1. All right, S1 and S2. So as the PR interval gets longer, the PR interval is going to be reflected by the time between activation of the atria, which is going to take place here, okay, because this is the passive filling. This is the passive filling of the ventricle, and then you get in the late stages of diastole, you get active contraction of the atrium, left atrium, and filling. So the PR interval is going to be the time from here where you get activation of the atrium until here. Okay, so as this interval gets longer, confused now. I used to know this. Give me 1 second. Huh?
Is it the
Huh?
S4 to S1 that gets longer, or is it the S1 to S2?
No, these are determinants of the intensity of S2. All right, let me move on to the next one, and we'll come back to the PR interval. It is one of the determinants. Okay. The second determinant is the condition of the valves. Okay, so if the valves are thickened and calcific, okay, that's going to affect the noise that they make. Of course, if they're thickened and still very mobile, they'll make a louder noise. But when they become thickened and then they're not moving much at all, then the intensity of the noise is going to go down. So the condition of the valves is going to affect S2's intensity as well. And then finally, the third determinant of S2 intensity is the rate of pressure rise in the ventricles. Okay, so as the rate of the pressure rises faster, okay, then the intensity of S2 is going to be increased. So a high rate of rise of pressure increases the intensity of S2. I'm going to look that up, and I'll tell you after the break, okay? Okay. Other things that can be associated with aortic stenosis besides the murmur and an alteration of the intensity of S2, patients can have abnormalities of the pulse. So you can develop a pulse called parvus and tardus, which means diminished and delayed. Patients can complain of angina. Now, why do they get angina with aortic stenosis again? We talked a little bit about that. There's a couple of reasons. There's two pathophysiologic reasons why somebody with aortic stenosis would develop angina. So give me one of them, but there's two reasons. Yeah.
The coronary arteries come up right off the aorta, right after the stenosis happens.
So okay, all right. So it's a decreased cardiac output. Okay, decreased cardiac output is going to be one of the reasons why somebody can develop angina. If the aortic stenosis is affecting the cardiac output, what's the other one? The other reason why they can develop it? Yeah.
You have insufficient flow to the coronary arteries.
Yeah. Couple of different reasons, but related to that. If you thicken the muscle, you increase the demand. Okay, so patients that have aortic stenosis have increased muscle, which means they have increased needs for oxygen. And so all other things being equal, that's going to tend to produce angina. And if they have decreased cardiac output, that's only going to make it worse. And then remember too that the myocardium perfusion of the left ventricle is during diastole, okay? And so, to the extent that, and it's dependent on differences in pressure between the pressure in the coronary arteries and diastolic pressure in the left ventricle. So as the diastolic pressure in the left ventricle goes up, that's going to tend to impede perfusion of the myocardium, particularly the subendocardium, okay? And we already said the left ventricular pressure, diastolic pressure goes up in patients that have aortic stenosis because of hypertrophy, right? All right. Other things that can happen with aortic stenosis, remember we said, besides developing angina, they can develop syncope, and they can develop congestive heart failure, right? Angina comes first, then syncope, and then congestive heart failure. Okay, let's take a break. I'm going to look up why that PR interval, how that PR interval is related, and then I'll come back at 11 o'clock.